Good afternoon. We have with us Dr. Akhil Taneja, intensivist at Max Hospital, New Delhi. And we welcome you to the Natco Pharma Specialty Criticon Studio. We look forward to your advice, the young generation of doctors, those who are associated with critical care and especially with bacterial resistance treatments. Doctor, what are the changes you have seen in critical care management?
So, as this session is about multi-drug resistant bacteria and growing gram-negative and positive resistance, see, when I joined critical care, it was about 14, 15 years back. Most of the bugs, they were ESBLs in our ICUs. Now, most of the time, we are getting carbapenem resistance. So, in a span of 1 decade or 10 years, we have moved on from ESBLs to carbapenem resistant bugs. And this is solely not a responsibility of one person or one doctor. It is a teamwork which matters. So antimicrobial stewardship is not a responsibility of one person. It is all about teamwork. Every person working in ICU in his or her own capacity should always be watchful about using and misusing antimicrobials in the ICU. So that where the crux lies. When every person contributes, the results will come.
Thank you for defining antimicrobial stewardship being the work of all. How would you advise the young doctors in the ICU for patient care enhancement?
So first of all, be honest to yourself. That is my advice. Be honest to yourself, be honest to your patient. And while working in ICU on daily rounds, always look for what drugs they are getting, whether they are needed or not. You should always be countering the other person who is adding unnecessary antimicrobials. You should always be asking the questions. That's where the core lies.
You didn't speak about carbapenemus, to some extent, but what is the prevalence of carbapenemus in your
No, it actually varies. It actually varies from ICU to ICU to hospital. So every person has to look after their own epidemiological data. So at my place, approximately 20 to 30% of all reported bugs are carbapenem resistance. And that's in the medical ICU. But then again, we have neurosurgical areas and then CCU areas, CTVS areas. There the prevalence goes down. But in medical ICU area, probably it is a little on the higher side.
how do you mix the treatment options in such cases?
See, over last 5 to 7 years, we have been using polymyxin B based therapies only. Now, the recent trend is going towards use of Zevicefta or what we can say ceftazidime avibactam along with the azathionam combination for MDR GNBs. But then the strategy is modifiable patient to patient, bug to bug. For Pseudomonas, you have to use different strategy. For Acinetobacter, there is a different strategy. For Klebsiella, again, so patient to patient modification has to be done. But the core lies with the polymyxin based therapy as well as the newer combinations including ceftazidime avibactam with azathionam and sulbactam and minocycline for Acinetobacter pneumoniae. Yeah.
Dr. Taneja, we value your time spent in the studio and we wish you all the best on behalf of Natco Pharma Specialty. Thank you so much for your time.